Okay.
Okay. All right. So thank you everybody for coming. My name's Emily Nellett. I work here on the 6th floor. I'm an oncology nurse. So I went to a conference at New York Presbyterian about oncologic emergencies with Katie Shea, another nurse here, and we put together this presentation for you guys. We just felt like it was really pertinent and valuable information, and we wanted to bring it back and apply it to our population. Which button is it still?
To the arrow on the right.
Oh, I see.
Just hit it once and the slides will hit this one right here. This one
Okay.
right here. Okay.
So we broke it down into metabolic and structural emergencies. So metabolic includes things like neutropenia, sepsis, disseminated intravascular coagulation, tumor lysis syndrome, and syndrome of inappropriate diuretic hormone. These are all things that occur in, other populations, except for the tumor lysis syndrome can only really occur with a tumor, which you have obviously in the oncology patients. But this population is very high risk for these conditions. So that's why they're so important for us to know about. So neutropenia, as we all know, it's a decrease in the neutrophils. So here at the hospital we use 2,000 as our absolute neutrophil count, or we use 1,000. The conference recommended actually using a number for ANC of 2,000, just to kind of protect those immune compromised patients even more, but our policy here is 1,000. So febrile neutropenia is really an oncologic emergency, and we see that a lot here. It's associated with a 70% mortality rate that increases as therapy is delayed. So that's why it's so important in this population when we see a fever, neutropenia, that we really address it early. We have our septic protocol that helps with that, but we'll talk about that a little later. So early recognition is the biggest, thing to remember with this. So if their white count is low, they're not going to be able to fight off these infections. So you want to be assessing them constantly, for any respiratory or urinary symptoms. We want to be checking their skin, and if they have any indwelling devices, that's a huge risk for developing infections. So these are all things we want to be mindful of, and we want to be escalating those so we can help prevent morbidity and mortality. It's important to remember too that hematologic cancers have a huge risk of neutropenia. That's because the treatment for these cancers is actually to suppress the bone marrow. So that's an important thing to remember, that these patients are going to be at the highest risk. So things we do well here at Northern Westchester, we always do, our PPE, our hand hygiene, limiting sick contacts. And I think when patients are neutropenic, we're especially careful of this because we know how vulnerable they are. We do basic safe food handling, no fresh plants in the room. We try to prevent harm and trauma, no pet visitation. Some things that we could do a little better, I think oral hygiene and respiratory hygiene are really important in preventing pneumonias. That's a common infection for neutropenic patients to get. So it's just, a little food for thought of how we could improve even more and try to not only identify febrile neutropenia early, but help to prevent it. So sepsis, this kind of goes along with the febrile neutropenia because the low white count and fever are two things you might see in a septic patient. So just to kind of recap, sepsis is a systemic inflammatory response to a pathogen in the blood. So the body's response to that infection is really what's creating all these issues. So some really high risk factors, immunosuppression like we talked about, myelosuppressive chemotherapy, so that's suppressing the bone marrow, like with all those blood cancers. Loss of skin or mucous membrane integrity, so that's sores in the mouth, not having good nutrition, skin breakdown, long intensive care stays, and again, indwelling devices. A great tip that was brought up at the conference was about the chlorhexidine baths. So we do that here, And I think we have pretty good compliance, but sometimes we do get some pushback from patients. It's really a very important intervention. The way that they suggested at the conference to increase compliance was to tell patients it's a treatment to prevent infection. So rather than calling it, the chlorhexidine bath, to kind of rephrase it that this is a treatment along with other interventions we're doing to prevent infections. And then this is our septic protocol. I think we're all pretty familiar with this. And early recognition and patient advocacy are really key here. With patients who are getting chemotherapy and are, immunosuppressed, you might see that they're on prophylactic medications to prevent infections, such as like antivirals or, you've seen Bactrim. So just things to keep in mind. So the next one we'll talk about is the DIC, or disseminated intravascular coagulation. I don't think this is something we really see as often, so I think it's a good thing to review. This is a condition in which the blood clots throughout the body in the small vessels, and it uses up all the clotting factors and platelets, resulting in life-threatening bleeding. So you're clotting and bleeding at the same time, which makes it a really difficult emergency to manage, because you're managing kind of two opposite things. So risk factors that are specific to the oncology population include sepsis, malignancy, and acute promyelocytic leukemia. Some other risk factors not so specific to this population are trauma, complications of childbirth, surgery, and ABO incompatible blood. So in acute DIC, you'll see low platelets, fibrinogen, plasma factor, both 5 and 7. You'll see a high PT, PTT, thrombin time. So all of those things that would show they're not clotting well. In chronic DIC, it's going to take a lot longer to develop. You'll have clotting as more of an issue than the bleeding. So in acute DIC, you'll see a lot more of that bleeding. In the chronic, the PT, PTT might be normal. So again, symptoms would include bleeding or clotting. Clotting in chronic DIC, you might see like DVT, PE, stroke. In acute, you might see hematuria, hemoptysis, and acute change in vitals or mental status. Early recognition is the key. Treatment could include giving both things to make you stop clotting and to replace blood products at the same time. So again, it's a difficult emergency to manage because you're kind of tackling it on two different ends. Here we implement our bleeding precautions, harm risk, fall risk. So for a patient like this, that would be really key in managing them. Tumor lysis syndrome. So we've seen this a bit here on the 6th floor, but it's great to review. So this is when a large amount of tumor cells break down and release life-threatening acid and electrolytes into the body. So big risk factors here are bulky tumor, small cell lung cancer, leukemia, lymphoma are some common ones that we see this with. And in assessing your patient, you're going to see high uric acid, potassium, phosphorus. And then if they're dehydrated before they get chemo, that's a huge risk factor because all these things are going to be affected by dehydration to begin with. So then when the tumor starts to break down and release uric acid and potassium, it just further complicates things. And this is not isolated to just getting chemo or radiation that can break down a tumor. This can also occur from rapid growth. So it could occur, totally isolated of getting any treatment, which is not necessarily when you would expect it. So it's always a good thing to keep in mind, especially with all those risk factors. So again, the symptoms you would see in lab work: hyperkalemia, high phosphorus, low calcium, and high uric acid. You might actually have crystals in the urine from the high uric acid level, and you'll have edema, anuria, and EKG changes. So some important interventions for nursing are going to be to hydrate the patient. They'll give sodium bicarb to neutralize the acid. So a great example, we had a patient on the 6th floor for like 5 days. He was getting chemo for, I think he had one of the ones that we talked about. I think he had lymphoma, but he had a sodium bicarb drip through his entire 5-day stay. And that was to help prevent tumor lysis syndrome because he was at such high risk for that tumor breakdown. So some meds you might see given to help address the uric acid are allopurinol and rasburicase. The rasburicase is not only going to prevent uric acid from building up, it's also going to break down existing uric acid. So that would be the difference between the two. And it's a great point to keep in mind in terms of advocating for your patients, because oftentimes we'll be able to see the pre-chemo labs, so it's a good thing for us to recommend. And then you'll be treating the high potassium and phosphorus. Syndrome of inappropriate antidiuretic hormone, SAADH. So this is unregulated release of antidiuretic hormone that can cause the kidneys to retain water. The blood sodium levels will decrease as a result, and the urine is going to be very concentrated. So it's really a water issue, not a sodium issue. But the sodium is what you'll see in the lab work. Risk factors include small cell lung cancer, brain tumors, and also medications that patients might be on, so like opioids, antidepressants, NSAIDs, and anesthetics, which is a great point for us because I think a lot of our oncology population is on, pain management meds like opiates and NSAIDs, and a lot of them have depression and anxiety, so these are all risk factors. Symptoms, you'll see low sodium, thirst, nausea, headache, muscle cramps, and weight gain, but it's in the absence of edema because all the fluid is intravascular, so you're not going to see swelling, but in a patient like this, daily weights would be really important. So interventions, it's basically just trying to correct the fluid balance. So they might be on a fluid restriction, they're going to be thirsty and pretty miserable, so they'll need oral care. You might be giving Lasix to help them get out all that fluid, possibly seizure precautions if their sodium level's too low. And this is important in terms of correcting the sodium. Correcting it too quickly could result in cerebral edema, and that would definitely cause a seizure, and that's an emergency in itself. So that's why we want to be doing it slowly and definitely monitoring their mental status. So next is treatment-related emergencies. So these are hypersensitivity and anaphylaxis, and these would be occurring in giving chemo, which we do give on the floor. So definitely, even if you're not giving it, it's important to know. You can have delayed reactions to medications, so always good things to be looking out for. So hypersensitivity and anaphylaxis. This is a systemic allergic reaction. When anaphylaxis occurs, a cascade of events causes vasodilation, increased capillary permeability, bronchospasm, and coronary vasoconstriction. So risk factors, definitely, a brand new chemotherapy, but it depends on the medicine. Some you can also have a delayed reaction after multiple doses. So like carboplatin, the highest risk to react to that med is at the 7th or 8th dose. So not something you might be expecting unless you had looked that up in advance. So it's an important thing to know about the medicines you're giving. Chemotherapy drugs are ranked by their risk of hypersensitivity. So also a great, thing to look up before you're giving the medication. You want to know what to expect. And 4 to 6 hours after, you kind of have that delayed reaction. So always something you want to be watching for. Symptoms, I think we kind of know these, anxiety, flushing, throat tightening, dyspnea, angioedema, rash, chest tightness, cough, wheezing, all the things that scare us. So interventions, if you're giving chemo at the time, you want to stop it right away and hang saline, maintain the airway, and you'll be giving epi and albuterol for bronchospasms. This would be an RRT situation. So really, our main concern would be maintaining that airway until the team could come and we'd, initiate meds. So pre-medication is really common with these meds that have high risk for hypersensitivity. If the patient does have a hypersensitivity reaction, it's not uncommon that you might be giving the medication at a lower dose or, changing the rate. But with anaphylaxis, you'll never be administering it again. That's a contraindication. So next is structural emergencies. So these are things that are, physically going to be happening in the body, not so much the metabolic aspect. So this includes increased intracranial pressure, superior vena cava syndrome, spinal cord compression, and cardiac tamponade. Increased intracranial pressure is usually caused by fluid or a mass. So tumors that create their own blood vessels through angiogenesis tend to leak because the vessels that they create are really weak.